Hey everyone, today's video is on the surgical management of gastric adenocarcinoma. So, when we think of gastric adenocarcinoma, it's another of those pretty bad actors when it comes to cancer. And if you think about it, it's kind of like pancreatic cancer. It kind of sits there in the middle of the abdomen. It can actually progress pretty far before it causes any sort of symptoms. And so it's certainly at high risk of being unresectable when first diagnosed. And if you offer these patients the surgeries we're going to be talking about are pretty morbid operations. So the staging workup is going to actually be a little bit more intense than some of our other cancers because we really want to avoid unnecessary surgery and there is such a high risk of it having spread. So keep that in mind as we think about these workup tests. Now, surprisingly, unlike some other cancers, labs aren't really playing a big role when it comes to the workup of gastric adenocarcinoma. If there's some sort of confusion with potential other foregut malignancies, you could consider something like a CEA or a CA19-9, but these are not necessary per NCCN guidelines. Imaging, just like most of our GI tract cancers, we would get our CT oncology, our CT chest, abdomen, and pelvis, usually with both IV and oral contrast. But what's different is if we get these imaging and there's no sign of distant metastatic disease, then we would also follow that up by getting a PET CT scan to look for any more occult foci of disease, which remember, PET CTs aren't used that often in cancers, in our cancer workup, so that's a little bit different from some of our other GI tract cancers. And then there's also several other tests. So first, of course, you have your EGD with your biopsy. This is probably how you diagnose your gastric cancer in the first place. But then once you have a diagnosis of gastric cancer, it's very important to get your EUS or your endoscopic ultrasound. This is very important both to tell us about the depth of invasion, which will give us our clinical T staging of the tumor, as well as look for any localized nodal disease, which is going to be very important when we think about who gets surgery up front or who ends up getting neoadjuvant therapy. We'll talk about that a little bit more later. The other unique test is a diagnostic laparoscopy. And so, in anybody who's going to get surgery, upfront surgery or surgery after neoadjuvant therapy, we typically do stage them up front with a diagnostic lap, looking for any subtle peritoneal disease, which can often be missed by CT scans. And you also get peritoneal washings for cytology as well. Um, it's a little bit controversial who exactly gets it, but you definitely should have at least the thought of diagnostic laparoscopy in your mind when you're thinking about the staging workup for gastric cancer. All right, so now we've gotten all our data and it's time to actually stage the patient. So our T staging, remember this is typically based on our EUS results, comes in a few key flavors. Well, I guess what I'm trying to say is, while the categories are pretty much the same as most other GI tract cancers, there are a few key transition points we need to be focused on. So first is the difference between T1A and T1B. Remember that T1A disease involves just invasion into the lamina propria, whereas T1B invades a little bit farther down into the submucosa. T2, T1B versus T2 is another key distinction point. T2 involves invasion into the muscularis, autocorrect there, propria. T3 goes into the subserosa, and then T4 goes into the serosa, the surrounding tissue. Our end staging, again, pretty typical for most of these GI tract cancers. N0 has no nodes, N1 has 1 to 2, N2 has 3 to 6, and N3 has greater than 7 nodes. Although typically when it comes to surgery, we kind of really just care about the differentiator between no nodes and any nodes. And then M staging, always the easiest. M0 means no metastatic disease, and M1 means distant metastatic disease. So who with gastric cancer is a surgical candidate? Well, first they have to be M0, right? Unless we're talking about palliative surgery with bypasses or surgery to prevent bleeding or things like that. Generally, we do not offer surgery to patients with distant metastatic disease. Then they need to have resectable disease. So in this case, we need to ensure during our staging workup we see no invasion into the root of the mesentery, no encasement of major vascular structures, with the exception of the splenic vessels, but things like the celiac arteries, the common hepatic, etc., those would all be unresectable. And then we cannot have any peritoneal disease. Remember, that can be often diagnosed on that diagnostic laparoscopy or those peritoneal washings sent during diagnostic laparoscopy. But assuming somebody has no distant mets, they do have resectable disease, and they don't have any prohibitive medical comorbidities to undergoing surgery, they would technically qualify for surgical intervention on their gastric cancer. Now that we've talked about that, of those patients who would potentially qualify for surgery, who would undergo neoadjuvant therapy with either chemotherapy or chemoradiotherapy, both of them are options. We're not going to go too much into the specific regimens today. And those patients would be anybody with T2 or greater disease or any nodal disease. Now, getting a little bit more into the details of surgery itself, we need to think about our CWORK classification. I believe we talked about this back in our esophageal cancer video. But if you don't recall from that, remember this is all based on the distance from the esophagogastric junction, shown by these squiggly lines right here. And so a type 1 is either 5 centimeters proximal down to 1 centimeter proximal. So these are truly esophageal cancers. Then type 2 kind of abuts either side of the EG junction. So 1 centimeter proximal into the esophagus or 2 centimeters distal into the stomach. And these are both really classified as esophageal cancers and treated, like we talked about in that video, primarily with an esophagectomy, etc. So it's really only the type 3 sewer gastric cancers that we're talking about in this video. And those are defined as from 2 to negative 5 centimeters. Of course, any cancer that doesn't even qualify for CWORK classification, so more than 5 centimeters away from the G junction, is also treated in this fashion. All right, so we've laid a lot of kind of theoretical classification groundwork here, and now we can finally talk a little bit more detail about our surgical options. So first, we need to consider our T stage, and that's because, especially in the stomach, there's a lot of options for endoscopic resections where there weren't for some of our other types of cancers. So if we have a T1A, remember T1A is invasion into the lamina propria, those patients would qualify for an endoscopic mucosal resection, or they could get surgery up front if it was preferred based on the patient surgeon's discussion. And down here I have a little picture of kind of some representative EMR, endoscopic mucosal resection techniques. So if you have some sort of pedunculated cancer, like shown up here on this top row, you can just put a snare over it, snare it off, remove that completely. In certain situations, that can be enough both to diagnose the cancer and to treat it. However, for a more sessile polyp, a lot of times they have to do a submucosal injection where they inject some saline here, and then they're able to get some sort of snare and remove that polyp. And so endoscopic mucosal resection, again, can be both diagnostic as well as therapeutic. And that's if the cancer meets a few specific categories. It has to be pretty small, so less than 2 centimeters. Has to be well or moderately well differentiated. It cannot penetrate past the superficial mucosa. There has to be no lymphovascular invasion. And then once you've done your resection, you must have negative deep as well as lateral margins. So if they have an early stage cancer, T1A, and they meet all of those criteria with their endoscopic mucosal resection, that patient is surgically complete. They do not need additional surgery, although they will need post-procedure surveillance. Now, if somebody has T1B disease, remember T1B involves invasion into the submucosa, those patients would qualify for surgery as opposed to EMR, and they would be able to get that surgery up front without neoadjuvant therapy. And then finally, for patients with T2 disease or beyond, so any T2 or any positive nodes, if they are a surgical candidate, if they are resectable, then they would qualify for neoadjuvant therapy followed by surgery. So since this is mostly a surgically focused talk, we're going to ignore about endoscopic mucosal resection for now and just assume we're talking about kind of patients getting invasive surgery, full surgery, as it were. And so there's actually a lot of options. And you can kind of mix and match your techniques for the resection, right? We have to cut out the cancer. Then we're going to have to do our reconstruction or reconstruct the stomach or something to approximate the gastric or GI tract continuity in some fashion. And then we have to do some sort of lymphadenectomy as well. And so your options when we're talking about resection, I have in red here esophagectomy. Remember, if you're doing an esophagectomy, these are those either CWORK 1 or 2 tumors up here in the esophagus or very close to the GE junction. And those are basically treated like esophageal cancer. So we don't really think about an esophagectomy when it comes to gastric cancer, but it should be kind of on your radar as a surgical option for patients with certain types of diseases. Now, those with true gastric cancers, you have several options depending on the location. So if you have a tumor that's more distal here in the stomach, you can get a distal gastrectomy, where you cut the stomach somewhere here in the middle, you remove the entire distal stomach. If it's maybe a little bit higher up, you might do something called a subtotal gastrectomy. That's where you cut the stomach, just preserving kind of the GE junction, maybe a little bit of the cardia, and then you take out the entire rest of the stomach. So a subtotal gastrectomy. If it's too high even for that, you can do a total gastrectomy where you remove the entire stomach. And then finally, for certain situations where you have proximal tumors, you can actually do what's called a proximal gastrectomy, where you cut down here, leave this distal part of the stomach, and then you remove the entire proximal aspect of the stomach. All right, and then depending on the type of resection that you've done, you can do various types of reconstruction. So for your distal gastrectomies, you can do any of these three. So we have Billroth 1, Billroth 2, and a Roux-en-Y reconstruction. And so Billroth 1 and 2, these are just for distal gastrectomies. So let's say we've cut the stomach here and here. So now what we have left is some sort of remnant stomach and then the duodenum down here. So Billroth 1 is where you just bring up the duodenum and you do a gastroduodenostomy, where you hook up the duodenum directly to that remnant stomach. Oftentimes difficult because there's a lot of space to traverse here, difficult to mobilize the duodenum and to get a tension-free anastomosis, but it is technically an option. I would say more common is a Billroth 2 anastomosis. Again, we've done a distal gastrectomy, and in this case, we leave the duodenal stump where it's at. But somewhere down here in the jejunum, there's our gastric remnant up here. We bring up a loop of jejunum up here, and we do kind of a side-to-side anastomosis of the stomach to the jejunum. So you have this afferent and efferent limb, and your stomach contents can drain down here and go to the rest of your GI tract. Now, a Roux-en-Y reconstruction, we've talked about pretty extensively in our bariatric surgery videos. But again, this can be used very flexibly, right? So really the definition or kind of the fundamentals of what a Roux-en-Y is you somewhere down in the small bowel make an incision, and then you have a BP limb down there that's going to get plugged in. You can bring up this distal loop of jejunum, and you can plug that into anything you want, right? You can use it to plug into the common bile duct for a hepatic OJ. In stomach surgery, you can either bring it and plug it into your gastric remnant. If you've done a distal gastrectomy, you could bring up a loop of jejunum and plug it in there, kind of like you would for bariatric surgery. Or if you've done a total or subtotal gastrectomy, you can do a complete esophagojejunostomy with that sort of Roux-en-Y limb, the Roux limb all the way up to the esophagus. And your final option, the double tract reconstruction, this really only applies to a proximal gastrectomy. It's a way that you can do a proximal gastrectomy without having to do a total and without having some of the bad side effects of proximal gastrectomy, such as really bad acid reflux, aspiration risk, etc. And so a double tract reconstruction, remember, if we've done a proximal gastrectomy, we've taken out this proximal part of the stomach, but we still have some distal left right here. So if I draw that here, here's your duodenum coming up into what's left of the antrum of your stomach. And up here you have your esophagus, or maybe a little bit of gastric remnant up there. And in a double tract reconstruction, you bring up a Roux limb. So you bring up a loop of jejunum that's going to come up here, and you're going to do kind of an end-to-side anastomosis to your jejunum there. Then your jejunum is going to come down, and then you do a side-to-side anastomosis here to the residual antrum. And then somewhere down below, you're going to plug back in your BP limb to your Roux limb as well. And so what this does is it helps prevent these patients from getting as many nutritional deficiencies, since the stomach can still make things like intrinsic factor and kind of mix that in with the rest of the food coming down this way. All right, so a lot of data there, but finally, in addition to our resection and our reconstruction, we also have to make sure we have a good lymphadenectomy. It's very important to get a good amount of lymph nodes when we do this procedure. And so depending on where you are and what the local practice patterns are, you'll either do a D1 resection, where you're just taking the perigastric nodes, I think of those just kind of encircling the stomach, or a D2 resection, where you get both the D1 perigastric nodes, but you also extend your lymphadenectomy to include basically the major vessels of the celiac axis. So you get the left gastric nodes, the splenic artery nodes, hepatic artery nodes, and the celiac axis nodes as well. All right. And so you kind of mix and match those principles of surgery, those options for surgery um, based on following all these principles of surgery that you can and minimizing the morbidity for the patient, right? So we want to make sure we get a really good lymph node harvest. Typically, you want around 15 or 16 lymph nodes. You also want to get good margins. Technically, NCCN says it only really matters that you have negative margins, but in order to get enough lymph nodes, you're going to need bigger margins than that. And I would say the classical teaching that I've most often heard is you're shooting for around a 5 centimeter margin. Remember, we want to do as little morbidity as possible. So at one time, it was question: should we always take the spleen out? The answer is no. Only take the spleen out if it's definitively involved in this surgery. And then finally, you have to remember that T4B tumors, or tumors that invade through the serosa into surrounding structures, need to be resected with those structures unblocked with the stomach to have a true oncologic resection. And so, again, depending on exactly where the tumor is located in the stomach, you may end up having to do a distal gastrectomy, proximal, total, subtotal, etc. You generally want to take out the least amount of stomach that you can to give your patient the best chance for some good postoperative function, but you do want a good oncologically sound operation that adheres to these principles. And then finally, post-op, who gets adjuvant therapy? Honestly, it's kind of difficult to understand the NCCN guidelines, and I'm not really going to try to do them justice here. I'll just say that, again, gastric cancer being somewhat of a bad actor, most of these patients will end up getting adjuvant therapy, and certainly they'll be presented at tumor board to discuss this after your resection. And then again, surveillance post-op, this is pretty typical of most GI tract cancers. So you're going to get an H&P every 3 to 6 months for the first 1 to 2 years, and then 6 to 12 months for the next 3 to 5 years, and then CT chest, abdomen, pelvis every 6 months for 2 years, and then every year for 3 years. What's interesting is they said EGD is only as clinically indicated. There's no like standard requirement to get EGDs after these operations. All right, so kind of a packed video there. So to review some of the key points, remember the staging workup. This is a kind of insidious occult cancer. We want to look really hard before we put our patients through these very morbid operations if they're not going to have any benefit. So remember, there's not really any lab workup, but we do get the CT chest, abdomen, pelvis. And if that shows us METs, you're done. But if it does not show you METs, you're going to take that one step further and do a PET CT to look for occult METs. Remember that you've gotten multiple scopes. You get your EGD with your initial biopsy. And then if you have a diagnosis of gastric cancer, you're definitely going to want to go back with an EUS to look for depth of invasion or any nodal disease to guide subsequent therapy. And then also remember that you should be thinking about, should this patient get a diagnostic laparoscopy before their surgery or their neoadjuvant therapy. Remember the criteria for resectability for these patients. Of course, they need to have adequate medical health to undergo a major abdominal operation, so no major comorbidities that would preclude them from doing that. You also want to make sure that they have, no distant metastatic disease. And then finally, no local invasion that would preclude resection, which includes peritoneal disease, which is often found by your diagnostic laparoscopy, no invasion of the root of the mesentery, and no encasement of major vascular structures, with that major exception being the splenic arteries, or splenic vessels, I should say. Remember that you have multiple operative options for your very early stage disease. You have endoscopic mucosal resection, can both be diagnostic and therapeutic. If it's a little bit more advanced than that, then you would do surgery. And just to put specifics on this, right, T1A can potentially get endoscopic mucosal resection. Patients that are T1B can potentially get surgery up front, and patients that are T2 or have any nodal disease should definitely get neoadjuvant therapy prior to potentially getting a surgery. And then remember that we have to decide what's our Seward classifications for tumors that might be close to the GE junction, but assuming it's Seward 3 or true gastric cancer, then you have your various types of surgical options based on where the tumor is in the stomach, with the most common probably being a distal gastrectomy or a subtotal or total gastrectomy, sometimes a proximal gastrectomy with the reconstructions that we talked about being, again, either the B1, the gastroduodenostomy, B2, gastrojejunostomy with that loop GJ reconstruction, or a Roux-en-Y being the most common. And then remember, you want that good lymph node harvest, and remember your difference between your D1 and your D2 lymphadenectomy. D1 just perigastric, and D2 perigastric plus those named celiac axis vessel lymph nodes. All right, so that's it. These videos are for educational purposes only. Don't use them to diagnose or treat any diseases. It's not clinical advice, and we will see you next time.